Okay, today our lecture is going to be about endodontic periodontal relations. Now, the tooth structure is coated or covered by periodontal ligament. That's why the tooth, anything happening to the tooth might affect the periodontal ligament, and vice versa. Any infection happening to the periodontal ligament might in the future affect the pulp. Clinically, any periodontal ligament swelling or a lesion can be seen as a swelling just below the gingival area. Here, this is the area when we see such a swelling. This is a periodontal lesion. But when we see there's a discoloration, that might indicate to us endodontic problem due to trauma, and the tooth may be necrotic. That's why we may consider that this lesion be endoperio lesion. Radiographically, it can be seen like this is the apical radiolucency, and it may be seen in the bifurcation area as a radiolucency. Lateral canals may be a source of exit of bacteria to the periodontal ligament area. As we can see here, laterally positioned lesions, both mesially and distally. After endo treatment, you can see that there are two very large lateral canals, and you can see after treatment the healing of the periodontal lesion is starting. You can see here this big lesion is associated with the main apex and with a lateral canal. Now, when we classify endoperio lesion, they may be, it depends on the cause. So it may be endodontic lesion or perio lesion, or it may be a combined through lesion. So it all depends on the cause. For example, endodontic lesion is related to the cause is due to the bacteria inside the root canal. So our treatment has to be endodontic treatment to stop this invasion of bacteria to the periapical region. If we don't do endo treatment, what will happen is that the lesion is going to increase in size. It will, the pus will extrude in the easiest way, and this is in the vestibule area, maybe mesially, distally, or buccally, or sometimes it will go up buccally and lingually until it reaches or destroys the periodontal apparatus and opens in the gingival sulcus area for pus to ooze outside. So this is for the pure endodontic lesion. But endodontic lesion with periodontal involvement might happen when we have the main cause is bacteria inside the root canal, and it extrudes through the bifurcation area through a through a lateral canal, or through another lateral canal in the gingival sulcus area, or it exits to the periodontal ligament area through the main apex. So this will mean that we will have a problem that starts endodontically and ends periodontally. Now the treatment here has to be both treatment, endo and perio at the same time. As you can see here, this is a very extensive lesion, started apically and destroyed the distal part of the tooth from bone. You can see here after treatment endodontically and periodontally, you can see that the lesion is gone and bone support has started and is gained. This is one of my cases. You can see this bifurcation area. There's a bone loss just by endo treatment and periodontal curettage. You can see the start of the bone formation in the bifurcation area. Another type of lesions, endoperioral lesions, are the primary or what we call the periodontal lesions. These lesions start periodontally. We can see them when we've got inflammation in the gingival area or swelling in the just below the gingival sulcus, and this is a cause. Through the gingival sulcus, the bacteria enters to make a periodontal problem with, of course, a lot of plaque and calculus, or if it goes down and destroying the periodontal apparatus, we will have a periodontal pocket, and any exit of lateral canal or large dentinal tubules, the bacteria might enter to the root canal and makes an infection in the endodontic field, or if the perio lesion goes down even further to the apex, we will have invasion through the apex to the root canal. So they may be due to the gingival crevice or through an extensive periodontal pocket apically or through lateral canal. In order to analyze the source of the lesion, if it is periodontal, we place gutta percha cone inside the gingival sulcus area that has got bone loss, and take an X-ray to see the source of infection. And here you can see that we've got a very big periodontal lesion that has extended to the apical part of the root. In this case, we have to start periodontally and analyze the vitality of the tooth by vitality test. And if the tooth is non-vital, we do endo treatment with it. Through combined lesions, this is a case where a patient comes to us and we take an X-ray and we see a very extensive lesion, both apically and laterally. Here we start our treatment immediately, both endo and perio at the same time. This is one of my cases. You can see the lesion is so extensive. We started lesion healing or treatment and periodontal treatment, and you can see complete healing. The endo-perio relations, one of them is the developmental grooves. This happens mostly in the palatal side of the maxillary lateral incisor. You can see there's a periodontal lesion here, but the tooth seems very healthy. It is vital, but we've got signs of periodontal problems. By reflection, you can see that this is a groove. So any periodontal problem happening and bacteria entering to the gingival sulcus area, if it reaches this groove, it will enter to the apical region without any problem and make this lesion. Of course, in this case, treatment is by extensive surgical intervention or extraction. In molars, when we have got one of the roots with gingival or with severe bone loss, or there's a problem with the endo treatment that cannot be treated, we may do hemisection. And hemisection is by cutting the tooth in half and removing the part that is acute. For example, this tooth that has got a problem with or extensive lesion here in the mesial root, excision like this, we do hemisection. Sometimes when we've got extensive bifurcation involvement, but the endodontic treatment is very well, the bone support is very well, we do the hemisection and leave them to crown them as two separate teeth. In the maxillary molars mostly, we made what we call root amputation. For example, this distobuccal root was destroyed by extensive root resorption. Instead of removing the whole tooth, this area, the distobuccal root, was removed, leaving the tooth functional. Sometimes in cases of periodontal intervention or any problem starting from the in the root canal, like for example a perforation, as we can see here, perforation to the periodontal ligament, we may treat this by cleaning the area and placing biodentine or MTA for good healing. So this case, when it starts from the root, from the pulp, and the problem happened due to the dentist, and it ended up with a periodontal lesion, it can be treated through the pulp chamber and very good.